conducting my Oh, yay, you got the recording. Um, I'm conducting my dissertation study on infant feeding decisions among people living with HIV here in the United States. A little bit of how we're going to spend our time together this evening. I want to talk a little bit about who I am outside of what I just shared, as well as the background and significance, why I'm doing this work, how I'm going to do this work, and what I hope the outcomes are. And then at the end, some questions and answers. Hopefully, I'll have the answers. Hopefully, you'll have the questions. So it should work out. So a little bit about me, how I came to do this work. I am a white, female, heterosexual mom of two amazing people that I breastfed for over 5 years. And through this breastfeeding journey, I developed my passion for lactation research, equity, and the desire to create change in how we support pregnant and birthing people. Since 2019, or I'm sorry, 2010, I had engaged in the education of doulas, nurses, physicians, and supporting parents in the wonderful world of lactation as a certified lactation educator and counselor. And while I did love what I did, I wanted to be a part of systemic change. So since then, I have graduated with my master's in health policy at UCSF, supporting birthing families as a registered nurse in both a high risk and public inpatient setting, and I've immersed myself in the research. I'm currently a doctoral candidate in the School of Nursing at the University of California, San Francisco, and I'm excited to continue my research focus on those who are living with HIV and making infant feeding decisions here in the US. So, since 2009, close to 2 decades of research has been used to understand the risk of HIV transmission via birth and breastfeeding, with the majority of this research generated in low income countries that lacked unlimited access to antiretroviral therapy or ART and affordable, feasible, accessible, sustainable, and safe for AFAS infant feeding modalities. Importantly, for those living in resource-poor countries, the avoidance of using human milk increased the rate of infant morbidity and mortality. Furthermore, these studies showed that exclusive lactation in conjunction with ART decreased the rate of HIV transmission. So, as a result, in 2009, the World Health Organization released a position statement recommending 6 months of exclusive lactation and have continued access to ART or antiretroviral therapy medication and retention in HIV care. This change in recommendations paved the way to support breast and chest feeding for those living with HIV globally. Now, evidence from the global research has discovered a wide range of facilitators and barriers to infant feeding decisions while living with HIV. These facilitators include cultural and community norms surrounding infant feeding practices, which shape how people made and sustained their infant feeding decisions. Fear of HIV disclosure and stigma due to a chosen infant feeding method. And this was often experienced when engaging in any infant feeding method that was opposite of the cultural norm. And finally, guidance from a healthcare provider was influential in any infant feeding decision due to the high level of trust and the optimal infant feeding guidance they received from healthcare workers. Furthermore, evidence suggests that advice and guidance from healthcare workers increase the odds of practicing exclusive breastfeeding. Barriers to infant feeding decisions include mixed messages from healthcare workers or authorities, including frequent changes in infant feeding guidelines, a lack of guidance on how to execute safe infant feeding practices in any form of infant feeding, and an absence of awareness of infant feeding guidelines by significant others. So globally, the complex relationship of healthcare guidance, stigma, and cultural norms significantly impacts infant feeding decisions while amplifying the need for explicit and informed support to achieve safe infant feeding practices. Research aimed at understanding experiences of lack of choice in infant feeding from resource-rich countries where human milk feeding has been contraindicated is limited. However, Etwa and colleagues examined how the intersection of race, class, gender, serostatus, or how much HIV viral load is in their system, and cultural social identity shaped how a specific mother feels about themselves, creating layers and unique vulnerabilities specifically for Black mothers living with HIV in Canada. Their work found that the intersections of social positions while navigating HIV diagnoses and links to HIV care made impacts on infant feeding, including fear of HIV transmission. Now, there is evidence to suggest not having a choice in how to feed one's child can have an impact on mental health while furthering HIV-related stigma that can create barriers to care. A metasynthesis conducted by Griswold, Pajano, Theron, and colleagues found that the intersection of infant feeding guidelines and maternal self-worth, culture of infant feeding, and adherence to guidelines contribute to HIV stigma. And they create barriers to shared decision making with providers and furthermore influence infant feeding decision making. Shapiro and colleagues conducted a study in Miami, Florida, after the change in guidelines and found that frequency of HIV testing, fear of HIV transmission, lack of breastfeeding education from providers, and social pressure to breastfeed as a barrier to breastfeeding while living with HIV. Facilitators included benefits of human milk, family and peer support, and educated providers in human milk feeding. Frequency in HIV testing is a similar finding in a study conducted by Ray and colleagues, which found that while breastfeeding may be a culturally appropriate version of motherhood, those living with HIV must also navigate increased surveillance and medical interrogations, which left participants feeling stigmatized and irresponsible for breastfeeding. Through the removal of infant feeding options, impacts on mental health, maternal roles, and HIV-associated stigma can have lasting effects and amplifies the intersection of infant feeding decisions while living with HIV. Health-related stigma, such as stigma related to HIV, is grounded in marginalization and oppression that is furthered by racism and systems of power, compounding by the experience of stigma. The combination of stigma and structural inequities that recent research has identified as either multi-level or double stigma and multiple stigmas result in discrimination and meet at social identities such as gender, race, serostatus, and class. Now, the impact on infant feeding decisions can move across the spectrum of the individual experience. Recent research found having separate infant feeding guidelines for HIV-positive parents creates stigma that impacts how people view their roles as mothers, their mental health, and how they will engage and seek support. Now, there's evidence that suggests HIV stigma may also play a role in engaging in shared decision making. With that in mind, I'd like to take a few minutes to discuss the engagement in HIV care within the HIV care continuum. The HIV care continuum is a public health model that outlines the steps people with HIV go through from diagnosis to achieving and maintaining viral suppression. These steps are diagnosis of HIV infection, linkages to HIV medical care, receipt and retention of HIV care with the goal of maintained viral suppression. During pregnancy, guidelines recommend a high level of care engagement, where these visits provide opportunities to optimize HIV treatment and minimize the risk of mother-to-child transmission. Along the care continuum, diagnosis of HIV that is established before or during pregnancy can happen during prenatal appointments, which then links people to care and the initiation of continuation of ART. Care engagement during pregnancy can serve as an entry point for women into lifelong HIV care. However, rates of retention in care and viral suppression and associated factors are limited for people living with HIV during the postpartum period in the United States. Recent national data shows that less than 50% of postpartum people are retained in the HIV care continuum. Measurements of retention of care include engagement in care within 90 days after delivery, at least 2 visits with an HIV provider in the first year after delivery, viral suppression within 1 year of delivery, and retention in care for 1 year postpartum. And barriers to engagement and retention in care in the HIV care cascade include low income, transportation barriers, substance use, and limited social support. There's an association of employment with suboptimal follow-up rates. And the women seeking care in the 3rd trimester were more likely to have suboptimal follow-up postpartum. An HIV diagnosis that's less than 2 years before delivery were less likely to be retained at 2 years postpartum. Recent evidence has found several facilitators to care that could be associated with infant feeding. Repeated infant infant-related healthcare encounters may be linked to maternal continuity of care, even if the encounters are unrelated to the mother's own care. Therefore, reduction in loss to HIV care in the postpartum year may be through interventions that target HIV-infected mothers during pediatric medical care, such as frequent infant and maternal testing when providing human milk. Furthermore, most infants receive care following delivery. Therefore, an integrated maternal HIV care with infant may facilitate early engagement in care. While there remain significant barriers to retention in the HIV care continuum, support in infant feeding practices may be a bridge to lifelong HIV care. Within the US, there is limited understanding of barriers and facilitators to infant feeding decisions, impacts of healthcare specialists, including lactation consultants, breastfeeding community support groups such as La Leche League, and social determinants of health that impact infant feeding decision making. Moreover, the influence of social structures and social determinants of health on infant feeding methods, including systemic racism, poverty, health policies like paid family leave, lactation work policies that include protection for people living with HIV. And there is a clear gap in the literature and the lack of understanding of infant feeding guideline changes and shared decision-making models between healthcare providers and those living with HIV. And finally, there is little understanding of the effects of infant feeding on engagement and retention of HIV care continuum. Therefore, to fully understand the experience of making infant feeding decisions in the US, it's important to understand where the US is situated and what we know. The benefits of human milk for both the lactating person and the infant have been well established and include the lowering the odds of infant mortality and the severity of multiple diseases in infants, which is why the American Academy of Pediatrics, the World Health Organizations recommend exclusive breast and chest feeding, meaning no other foods, waters, artificial teats, or bottles for the first 6 months of an infant's life. However, human milk has been contraindicated for those living with HIV since 1985. Now, the last 40 years have provided robust research that has changed practice and guided policies surrounding HIV in pregnancy, birth, and infant feeding. Recently, there's been a groundbreaking nationwide paradigm shift in the US regarding human milk among those living with HIV. In January of 2023, the Panel on Treatment of HIV during the Pregnancy and Prevention of Perinatal Transmission updated its guidance to recommend a shared decision-making model to discuss the benefits of breastfeeding and the risk of transmission. According to the CDC, before this administration, HIV transmission is less than 1% when exclusively breastfeeding and continue to have undetectable viral loads in pregnancy and postpartum. So to understand infant feeding decisions among people living with HIV, it's important to see the current landscape of HIV in the US. So the next few slides, we're going to take a look at HIV infection rates and who's been disproportionately impacted. While the landscape of HIV infections vary globally, however, in the US, high infection rates continue to impact birthing and marginalized people, primarily in the southern portion of the country. There is robust evidence that describes the impacts of historical traumas, including but not limited to forced medical procedures, inadequate health care, sexual assault, and lynching on Black communities, which have resulted in a lack of trust in healthcare systems and worse sexual health outcomes for Black women. Moreover, systemic racism has disproportionately increased infection rates among Black and African American community members. Factors such as poverty, unstable housing, education attainment, incarceration, and access to healthcare continue to amplify the disparities in access to ART, culturally appropriate care, lower rates of pre-exposure prophylaxis or PrEP, and trust in the healthcare system, which results in low viral suppression within Black and African American communities. As a result, in 2022, HIV infection rates were the highest among persons aged 25 to 34 who identify as Black and African American. Also in 2022, people assigned female sex at birth who acquired HIV through heterosexual contact accounted for 15% of HIV infections in the US, and 52% of those newly infected in HIV are located in the southern states. Due to contraindications of breastfeeding while living with HIV in the US, there is little information in the literature regarding the experience of those making infant feeding decisions while living with HIV. Therefore, the overall purpose of this critical ethnographic study is to understand what factors influence infant feeding decisions among pregnant and postpartum people living with HIV in the US. The specific aims of this dissertation include to describe infant feeding decision making for those living with HIV in the US at the intersection of race, gender, and class, and to explore systemic and institutional influences on infant feeding decisions for those living with HIV in the US. I'm currently recruiting through flyer distribution in community and reproductive healthcare settings, including perinatal infectious disease clinics, social media platforms, and community organizations serving pregnant and postpartum people living with HIV. In addition to, there we go. And my inclusion criteria include any postpartum person who has given birth on or after January of 2023, currently living with HIV in the US, aged 18 to 45, who speak, read, and understand English. So therefore, my exclusion criteria include non-pregnant capable people who have given birth before the January 23 change in guidelines, aged 0 to 17 or 46 and older, HIV negative, and read, speak, and understand a language that is not English, and live outside the US. My data collection consists of an online survey and semi-structured interviews of participants. The survey questions include demographic information, resources used, and experiences with stress and stigma. The semi-structured interviews will be conducted via Zoom or in person, depending on where they live. And interview questions include infant feeding intention, their experiences in pregnancy and postpartum, as well as parenting and impacts on social positions and systems. Data collection will continue until data saturation has been reached, and I have participant remunerations that will consist of a $50 gift card for each initial interview and $25 for after the second interview. This research is aimed at understanding the lived experiences of infant feeding decisions among those living with HIV in the US. And examining these factors will contribute to the limited body of knowledge surrounding the intersection of race, gender, class, and infant feeding decision-making while living with HIV. Moreover, this research will provide an understanding of the impacts of infant feeding guideline changes on how people living with HIV consider infant feeding options. Finally, the results of the study may be used to inform targeted institutional, community, and provider practices and interventions that aim to support those who are pregnant, birthing, and engaging in infant feeding decisions while living with HIV in the US. So the results of this research can add to the limited body of knowledge regarding the experience of making infant feeding decisions. For decades, breast and chest feeding has been a contraindication for those who are living with HIV, and this research is aimed at amplifying the voice of those who are birthing and parenting while living with HIV. While the recent shifting guidelines represents a significant step forward, the needs of those living with HIV are an imperative to structuring policy and community support. Thank you so much for your time. And if you have any questions or concerns, I would love to hear them. I'm going to stop share so I can see.
I have a question.
Yes.
And I think I mentioned it to you before because I'm always crying about our crazy way we think about things in this country. But the transmission rate is very low, it's 1%.
Less than 1%.
But we're talking HIV, so that's big scary.
Big scary.
So Do you mind sharing some of what are the steps that a parent can take to prevent transmission?
Yeah, that's a great question. One thing that we know for sure will help reduce that rate is keeping them at an undetectable viral load. So making sure that they are taking their medication, their ART medication, making sure they're going to get their HIV care. So part of that is an engagement in the HIV care continuum, which still allows them to get access to medication, to make sure that medication is working, and to make sure that they have an undetectable viral load. That's probably on the person side, that's probably
Right.
a significant factor. The other, go ahead.
I'm sorry, are we speaking on the binary here? Are we speaking about the mom and dad, their viral load, both of them, or just the one who's providing the milk?
Just the lactating person.
Uh,
However, if the dyad, the couple, are not undetectable, then hopefully they're doing something to protect each other so
Right,
that HIV transmission doesn't, or we don't continue to reinfect others.
like other STDs, we have to be.
Correct.
Yeah.
Correct. For the lactating person and infant, another way that we can reduce transmissions is by exclusive breast and chest feeding. So this is again one of those things where here in the US, we're going to get caught in a lot of those, what I think Samsara and I like to refer to as booby traps. It's very hard to exclusively breastfeed in this country for very similar reasons of what I shared in this presentation.
Mhm.
Systemic, institutional reasons, social determinants of health, all of these things that contribute or that add to barriers to exclusive lactation, including policies like paid family leave.
Right.
All of those things add uh, to that barrier, in addition to workplace policies, which are still not existent for people living with HIV. And in
Yeah.
part would require people to disclose their status at their workplace, which would be tragic because then you run the risk of
That's nobody else's business, but
yeah, exactly, exactly. So, but those two things are what we know to be the most effective way to reduce that less than 1% chance of transmission.
this is what excites me as a doula.
Right. This is where doulas come in. Yeah.
Well, yes, this is where doulas come in sharing this information. It's so vital. But also, my feeling way back in the day, I'm not a doctor, I'm not a nurse. I'm a doula and a person who lived through the HIV crisis when it started in New York and everybody was dying and everybody was freaked out, right? And understandably so. And just in my thinking as a person and a mama, um, if somebody has a virus of some kind, breastfeeding is the thing for the baby. The whole house has the flu, and the baby is breastfed. Baby's less likely to get the flu because the mom's body is making antibodies to whatever that virus is. So, correct me if I'm wrong. What I hear you say is if the parents are taking their medication and their viral loads are low, and they are breastfeeding, the baby is protected by that constant breastfeeding.
You know what? That's a great. I think where I'm hung up is protected. I would honestly like to say yes. However, we do know, just like how we understand breastfeeding to be, is that we have massive amounts of immune cells and fats and sugars and all of these things that contribute to adding or teaching this immune system how to function, how the infant's immune system how to function. But HIV lives in the immune system. This is what HIV does. It literally destroys our ability to fight infection. And
Right,
so if HIV are in our white blood cells or in our immune cells, and that is what is in going in breast milk, and that is what is going in the baby, then there's like that juxtaposition, right? That is human milk protective? Yes. But if we have a viral load that's detectable, then that's how we increase our rate. And to Maria's question,
Mhm.
you're saying the rate of transmission from mother to baby is 1%. I'm saying it's less than 1% in these circumstances of an undetectable viral load and exclusive lactation. It is less than one. What is it? We don't know because we haven't really done a lot of those studies here in the United States to see. What we do know is that studies that have been conducted in resource-rich countries, countries where there has been policies that have made human milk contraindicated because they have access to formula, they have policies in place that give people free formula, or these people have continued access to ART when they did change over their policy, found that there's been no transmission. But
Right.
those studies are small. They also are flawed. So really, we don't know. And hopefully we will know more as research is done in terms of if babies are infected, what does what is the rate of that infection? And also, does the type of birth have an impact? If that person is undetectable, then no. But that's an excellent question. And this is where we talk, I brought up very briefly in the presentation, when people living with HIV have lost um, bodily autonomy when it comes to birth in the context of their HIV viral load. So if um, for a person that has a detectable viral load, meaning they have virus in their body, in their blood when they have their blood drawn, uh, it's advised that they have a C-section because there is virus in the cervix and in the vaginal canal. And as baby passes through, then they have a high risk of being infected just through that process.
Do we have any of the cultures that almost nobody dies in? Norway, Denmark, Sweden. Uh, Lots of babies born at home
Mm,
and healthy. Do we have any information from those countries
mm.
on the effect of HIV from a vaginal birth as opposed to a cesarean?
That's a great question, and that's not something I think I can answer. However, I'm what I do know right now here in the States is that birthing people living with HIV are immediately high risk. So there is this question of whether or not birthing people would even be able to have home births. And I'm going to say this, I'm going to say like legally. I don't know if legally is the right word. Um,
I don't think there's any legal, at least I've not heard of any legality around someone with HIV having a home birth.
but can a midwife feel comfortable enough managing,
Yes,
right? And then you also have the criminalization part of it, right? Are people living with HIV giving birth at home? Will CPS be involved? Will infants be taken away? And that definitely happens within the context of breastfeeding. So I think
absolutely.
there's a lot of fear that is hovered around there too. But I'm sorry, Marie, I kind of went on this tangent. I apologize. Just so that I can make sure that I address your question. Yes, the rate, not necessarily, the rate of transmission from mother to baby in the context of undetectable viral load and exclusive lactation is less than 1%. And when it comes to birth, if we have an undetectable viral load by the third trimester in pregnancy, then this person can have a vaginal birth. If they had HIV infection in the third trimester or haven't been on ARTs and have shown an undetectable viral load, then they need to have a C-section for fear of transmission. Yeah, you're welcome. Sorry, it took me a second to answer that. I'm tired. I don't know why 7 o'clock on a Tuesday is a big, big
You
brain flex, but man, yeah,
sound
using words in complete sentences right now is whack. Ugh.
kind of whack.
Yeah, so please, if I didn't make that clear, please feel free to ask again. Hopefully I did.
Then after the cesarean, let's say this client is high risk, and if she's Black in America, she's getting a C-section.
Yeah.
Um, when can the couple be united, mom and baby, for breastfeeding after surgery?
If she has a detectable viral load, she will not be. Mm. Mm-mm,
So she
mm-mm.
hasn't. Her viral load is good. So
Yeah, so zero, if she has a zero viral load, and hopefully she should have the option to have a vaginal delivery.
mhm.
If not, then she could have that after a C-section. I'd hope that they would be reunited. However, I work over at Highland, and babies born to HIV positive parents have to have a bath after birth, which I I don't know what our statistics are of being at the very least have skin to skin in that first golden hour, regardless whether they're providing human milk or not,
Yeah.
before or after that birth. My guess, and this is a jaded person guess, is that there is probably no skin to skin after birth, that the baby will be bathed and then because healthcare workers will be reluctant to um, manage that infant because of that.
Are the parents at least allowed to bathe their own little baby?
Probably not in a hospital, no. But
Heartbreak.
that's an assumption. That's an assumption.
Yeah.
My guess is like again at Highland, probably not, because that's a risk.
It's a
However, yeah.
public hospital. Yeah.
But you've been a doula at Highland. Have you seen that option there?
I have yet to have an HIV positive client.
Mm,
All
hmm
the clients I've had,
hmm
so that's good and bad. It's good because that's heartbreaking, and bad because I don't have the experience of working with such moms and dads.
hmm
Um, but Highland, especially under their previous director, the previous head of OB, was very, very kind. And I've had some of my best experiences with medical people at Highland Hospital, but that was under the previous director. I don't know what the new guy's up to.
Yeah, I mean, I will say because we have such a large Black midwifery led
Mhm.
deliveries, I I don't know
It
about the bath if the mom or if the parents are allowed to bathe the infant. I'm assuming as a nurse, I would assume that we could do it together or that there's some way that we could have some kind of involvement in it. But again, I don't do labor anymore, so I don't even know what that would look like.
I completely feel you.
Yeah,
Uh, it's so I'm sure how the nurses feel, how the midwives feel. They're human beings. HIV is a big scary. Nobody wants to do.
no, nobody wants HIV.
It just makes me sad that the baby might lose is losing such a beautiful welcome to the world and
Right,
starting its immune system, being able to start get that colostrum and
right, right. And again, I don't know. I'm not making this. I'm making. I know that I've cared for HIV patients at Highland, and some of those babies have been bathed. I don't know if all of them have been bathed. So there's like that part. I do also know that people that have delivered at Highland that are HIV positive have breastfed because they have an undetectable viral load, and that hasn't been a problem. We have Brandy Fergus is there, Brandy Gay, she's the goat. So those babies are on the breast. Lactation consultants are there. Pediatricians are very well of the change in guidelines. However, having done this study as a pilot, I do know that there are um, several states, several hospital systems that still are not allowing people living with HIV to breastfeed despite their viral load. I also know that there are several institutions that, regardless of their viral load, are still being forced into cesarean births. Um, and so
heartbreak.
that is definitely still happening in the US, which is why I come to you all in hopes that you can share my flyer. I hope to capture all of those experiences because it's these experiences that we can share and publish that will hopefully help move the needle forward and really, like I said, like put a loudspeaker to these people's voices in hopes that we can really find what works and find what doesn't work. I do know that several people that I've spoken to living with HIV have not had the opportunity to have a doula. Um, And that has also impacted how they're able to advocate for themselves. Do you have
Absolutely.
any resources, literature to share that we can pass on to clients to advocate for themselves? Oh, you know what, Marie, that's a good point. I did put something on the Facebooks, um, some resources. What I will say, there is this one, I'm sorry, I'm looking it up now, that I share with HIV positive people. And this is actually a really great start and a good resource for doulas, I feel, called the Well Project. This is a advocacy group, a national advocacy group that talks about HIV along the gender spectrum. There's a whole section on breastfeeding or providing human milk. Um, mm, uh, mm, mm, there it is. Called BIBA, Building Equity, Ethics, and Education on breastfeeding among people living with HIV or breastfeeding and HIV. There's lots of great information here. Some stories of people's experience out um, national um, movements. I think I even, if I'm not mistaken, I could be wrong. Let's see. Hold on one second. I found that this was a really great website when I was um, learning about HIV among, yeah, learning about breastfeeding among HIV, because there's lots of great accounts, people sharing their experiences, lots of like, what do they call it? Blogs, that's still a thing. Vlogs, VL, like video. I don't know.
Mhm.
I'm old. Stuff like that, that really allowed me to do like these deeper dives in people's experiences, which I really appreciated. And it's run by people living with HIV. Uh, and so that part I really enjoy too. Any other questions or concerns? I'm more than happy to share my flyer. I think I can do so via the Zooms. And I also shared it with Samsara, but I'd love to share with y'all.
I
Oh,
I
I'm allowed to
believe
share.
I posted the flyer in our practice uh, WhatsApp, and I'll post it again in case people need it for some reason.
Yeah,
Um,
well, let me share the flyer with you all in the Zooms. It looks like it's a, I don't know, there's something going on there. But I'm more than happy. I'll share my email address. Please feel free to reach out if you have any questions or concerns or would like more information. Um, but yeah, I think it's, really important that doulas are aware. The doulas need to be trained, just like doulas need to understand lactation. And um, you all are really truly the bridge that's going to help us make it through birthing in the United States, um, and even more so for people living with HIV. So thank you for all that you do. And Samsara, always thank you for all that you do for continuing this and moving this forward throughout the generations.
I really think the closer we can get to new babies to their their mom's mammary glands,
Yeah, same.
that it will be good for them in the future. And who knows um, if people are even studying this kind of stuff anymore, which I really wish they would, like with other infectious things. Like th- I'm looking for protections
Yeah.
because our natural body's job, what our body naturally does is to fight against sickness, protect us from sickness if we do certain things. Like if you're eating
Right,
Cheetos and diet chips, you're not going to get much protection, right?
right, right,
If you're eating well and you're doing all those things that help your body to do what it's designed to do, which is to fight sickness,
right.
that's pretty exciting. I hope somebody's studying that somewhere.
Yeah, I'm also really interested in, we have these now long-term injectables. So instead of having somebody take a pill every day, they can have these injectables that provide coverage for, months at a time. As a matter of fact, before this administration came into office, we were right on the brink of a
Uh,
cure. Like we were right there. UNAIDS, the UNAIDS program, PEPFAR, all of these funded programs that were doing all these clinical trials were right on this cusp of the efficacy of understanding these vaccines and preventative strategies to stop HIV from being transmitted, and then also allowing people living with HIV to have these long, healthy lives that, yeah. So we were, as a matter of fact, right before this administration, a few people had said in my program that HIV is, it's almost going to go away. You're going to have to find another research topic. And I said, well, I mean, lactation's always been my bag, so I'm not worried. But yeah, unfortunately,
that man's going to the hot place. I'm telling you,
he is. He is.
going to. I can see the flames flicking at his butt.
Karma is an unforgiving, thankfully, an unforgiving energy.
Cutting
Um,
food stamps weeks before Thanksgiving.
wild, wild.
What a loser!
Oh,
Like he's not gonna, like he's not gonna eat, right? He's gonna eat well.
yeah, not for long.
Well, I try so hard. It is not my thing to hate anybody.
Mm-mm.
He makes it hard though.
I agree. I agree. Well, I guess we just got to keep on keeping on fighting that good fight.
Yeah, man.
Yeah.
Well, thank you for the work that you are doing. This is
Oh, yeah.
very exciting news to me as a doula. And when I'm doing birth plan, I'm already thinking I'm going to rewrite my birth plan book
Yeah,
because this is information that should be in there should you be an HIV parent.
I agree. I agree. It's definitely something that having done the research on it now is um we need to talk about it more within the birthing communities. We need to think about this more in terms of inclusivity and most definitely in terms of birth autonomy and recognizing, the impacts of marginalization and oppression. Yeah, it's time to end those things. Yeah, and it's always such a pleasure to be here. Always such a nice to share space with you again, Samsara. It doesn't happen
I'm
very often that much anymore, and so I'm gonna soak it in while I can.
a doctor. I'm looking forward to calling you
Oh
doctor.
my God. Oh
Looking,
my God. That's wild. Isn't that wild? That's wild.
I know.
Yeah. Stop.
It's,
Crazy.
yeah. Wherever I go, I was at a Black Women's Mortality and Morbidity Conference in
Mm.
Sacramento a few weeks ago, and I ran into two of our teen moms who are no
Mm.
teens,
Oh my God.
have three kids by now, all beautiful and void and
Mm.
in their professional life and having their kids, and they both came up to me in three different workshops, and said, "Hi, Mama, I'm sorry." And I was like,
Mm.
"I remember you. You used to be a little girl."
The baby. I know, man, that was awesome. That was such a great time, such a great
Well,
experience.
they loved you. They loved
Yeah, that was amazing. That was awesome.
you. Yeah.
Yeah,
So we got to keep doing what we're doing.
that's right. Keep on fighting the good fight, and it's up to doulas now, next generation doulas. You guys have to save the world. We're
Mhm.
here for it. We're ready for it. Set it
So
all on fire.
part of the way I feel we address this with clients is to let them know, show them the science with the studies. We'll look around, find that lovely website, get the studies that say what they say. But to remind folks, like with any of you want to have a natural birth, then you need to be following the rules.
Mm,
Mother Nature will send you to heaven. Okay, if
mm,
you don't listen to the rules, if you're not eating that protein, drinking that water, if you have too much stress, things will not go the way you plan.
mm,
So, having a zero viral load is super, super, super important for these
mhm,
parents.
mhm,
And good communication and being faithful to each other is super, super important to these parents. And so those are the things we'll talk about. We don't tell them what to do, but we do tell them how it is,
mhm,
the lay of the land, and they decide where they will walk, you know? And if they have a C-section, we help them to have the best C-section possible and be as close as possible and together and loving as possible. And if they can breastfeed, we definitely will come home smiling from that birth because
mhm,
that's where little newborns belong, right up under their mama's.
mhm,
That's where they
mhm.
belong.
That's right. So
So,
delicious. Mhm.
yummy. Any questions, my ladies? You're very quiet tonight. Everybody's tired and sleepy. This group loves to chat usually.
That's okay.
Are you still teaching classes like lactation classes, or are you just didn't you say you were doing, I'm sorry, you
Yeah,
said
no,
no.
that's
Okay, I'm
yeah,
like,
I
wait,
actually
did I
know
just
that. No,
mess it?
no, not at all. I think the last class I taught was for Samsara for her group of doulas. I think she's my last remaining. I haven't taught in a while because I'm in school and working. So she's really the only person I teach for now. But I do still teach. I do. I think that was probably one of my favorite, it still is one of my favorite things to do and talk about is lactation. Is so important for
So
doulas
good at it.
to truly understand how lactation works, because really the system is set up so much that much like birth, actually parallel mirrored to birth. The more interventions you have, the more it all gets, pardon my French, fucked up. So I love to have you all be aware of that. So number one, you could try to see it out and stop it and or find ways to help mitigate it and help your clients achieve their infant feeding goals. So yeah, Simsara was probably the last. I think I taught the last group. Was that a year ago, Simsara? I can't remember.
I
It all
think it
seems like
was.
like one long day.
I think it was the year before last year, and
I think
you
it
were
was.
at the breastfeeding festival
Mm,
last year.
yeah, yeah. So yes, but I do. I still love it. I still do it when I can. Whenever Simsara calls me, I'm there.
You're good to me. I appreciate you.
Mhm.
All right. So we need to say goodbye to you, my lovely friend.
Sounds good. It was so nice meeting you all. Thank you so much for your time. Like I said, my email is there. Please feel free to reach out. And Samsara, thank you again. Always such an honor to share space with you. Thank you for all that you do.
Thank you, thank you, thank
Okay,
you.
thank you, doulas.
I retired this year.
Did you? Oh, man,
I retired from hospital births this year. I can't,
that's a lot. It's really just,
I can't.
it's wild. It's
The
wild out
effect
there.
that's having on my body is not good.
Yeah, it's wild out there. Well, I cannot tell you enough how grateful we are for all the work that you've done. You've saved generations and generations and years and decades of people and their birthing experience, and the universe has quite the seat for you. Um, and we are so very grateful. Thank you. Thank you for everything. And I can't wait to see all the trouble you're going to cause next now that you're not in hospital
But
births. Oh my God, I can't wait to see you set fire to all the other shit.
good trouble is my middle name. As you,
Let's go. Well, I'm here for it. And like always, please feel free to call. It was such a pleasure to share space with you all. And again, so nice to meet you all. Good
happy
luck
turkey.
out there. Yes, eat all the good foods. Enjoy.
Bye bye. All right, beauties, let me turn off the recording.